Morning. I'm Todd Bohannon. I'm the Division Director of Vascular Surgery and Program Director at Baylor Scott & White in Temple, Texas. We're going to talk a little bit about lower extremity aneurysms. The majority of them, and the talk will be about popliteal aneurysms, as these are the primary component of peripheral aneurysms. This is just a little review of our anatomy in the popliteal artery, the popliteal region in the popliteal fossa. There's a lot of important structures that you'll encounter, particularly in a surgical approach. So one question is about what is an aneurysm and what is the normal diameter of the popliteal artery. It's roughly in the centimeter range, and we tend to define an aneurysm as being a focal dilatation of about greater than 50% of the normal diameter, which would make a popliteal aneurysm about 1.5 centimeters. 2 centimeters is roughly people's treatment threshold, just in general. The popliteal aneurysms are the most common peripheral artery aneurysms, about 80%. About 95% of them are atherosclerotic in origin. There's smaller percentages that are involved in trauma, adventitial cystic degeneration, entrapment, dysplasia, fibromuscular dysplasia, and infection and whatnot. This is primarily a male problem. Our males, in most all series, it ranges at kind of an average of 90% or more of males who have these aneurysms. And there can be found, just looking at some studies in regards to their different features or whatnot. One of the problems with aneurysms is associated other aneurysms. So almost half of people with a popliteal aneurysm on one side will have the contralateral one affected, and up to 40% or so can have a concurrent abdominal aneurysm and iliac aneurysms. Or one way of looking at it is if you have a patient with an abdominal aneurysm, a few percent may have a popliteal aneurysm. You always want to make sure you assess on physical exam and whatnot in regards a patient with an abdominal aneurysm looking for the popliteal regions. Even more so the opposite direction. If you have a popliteal aneurysm, in a unilateral popliteal aneurysm, about 40% of the patients may have an abdominal aneurysm, and it's even higher, up to 70%, if they have bilateral popliteal aneurysms. So you always want to, particularly if it has not been assessed in someone that you've been asked to see with a popliteal aneurysm, think about their aortic aneurysm. Now, in regards to clinical presentation, symptomatic-wise, it can be up to 60% of the people having symptoms, and electively treatments can be about 70% or so, with the urgence being less than 30. And this is just looking at the modes of presentation, again, about 40% asymptomatic, chronic ischemia about 40%, and acute ischemia about 20%. So risk for limb ischemia, very small risk of people who have small aneurysms, less than 2 centimeters. The larger you get, certainly the more risk you have of developing limb ischemia. And then some looks at ones that are larger than 3 centimeters can be up to 14% per year. Indications for intervention, certainly if they're symptomatic, ischemia, ischemic troubles, or compression. So those are the common ones we see in regards to symptoms. Now we also consider treatment in asymptomatic people as they get larger, so greater than 2 centimeters. We also look at the characteristics of the aneurysm, looking at the intraluminal thrombus, because there's a risk of distal embolization or acute occlusion. And if you have severe intraluminal thrombus, it may push you a little bit to an earlier treatment, as they may have a higher risk of limb loss or developing the poor runoff where they are chronically embolizing into their tibial vessels. Type of treatment is open and endovascular. Now in the open repair, which is the most common, Most of those are done by a medial approach, and we'll talk about that in a bit, and a smaller amount in regards to endovascular and stent grafting. So there are really not much open restrictions as far as open repair goes, other than you need to have a target vessel, and that goes along with most open vascular reconstructions. You got to have somewhere to have your bypass to flow into. In regards to endovascular popliteal artery repair, relative restrictions are the superficial femoral artery occlusion. If you have a thrombosis or rupture of the pulmonary artery, a very long pulmonary artery, say extending into the mid-superficial femoral artery where you'd have to put a whole bunch of stent grafts in, or if you don't have a good distal landing zone, so if it extends within a couple centimeters of the tibial-perineal trunk. Single vessel runoff is also not good, and certainly if you had to extend your stent into the, say, the tibial-perineal trunk and convert them into a single vessel runoff, then that would also not be a good one for endovascular repair. And in this study, looking at sort of open versus endovascular repair as far as people who would be eligible, it seemed like more people in the asymptomatic category were eligible for endovascular repair, looking at that type of criteria. When you progress to symptoms, certainly things may be more severe, then less would be considered non-eligible. Say 40% of those people may have occlusions, 20%, which is a single vessel runoff, using as exclusions. Now, in regards to open repair, there's elective versus emergent, medial versus posterior approaches, and using the different type of conduit. So, emergent repair is a independent predictor of limb loss. It has a worse 5-year patency. So electively, the 5-year patency of your reconstruction is probably in the 85 to 96% range. Now, if this becomes emergent, it's significantly less. So certainly is one reason why we try to get to these people earlier, and particularly in the big aneurysms with a significant thrombus. And the 5-year limb salvage is also significantly better in elective versus emergent repair. So the most common approach is the medial approach. It can accommodate any size aneurysm unless they're having compressive symptoms. So compressive symptoms from a very large aneurysm in the popliteal fossa, you saw all the structures that were in there. That would be a reason to consider a decompressive type procedure. Now, you can decompress it somewhat from the medial approach, but the posterior approach may be a bit better for that. It's important to exclude the aneurysm, let's say ligating it proximally and distally, because of you risk even more continued growth of the aneurysm. So even with the ligations, maybe up to a third of the patients still may have some enlargement in the popliteal aneurysm. In regards to the posterior approach, which is a fun and kind of neat operation, it's ideal for focal or short aneurysms, or certainly large aneurysms with the large that are having compressive symptoms. So you kind of expose and open the aneurysm sac, and it's almost like doing a mini open abdominal aneurysm repair and endoaneurysmorrhaphy. That way you can ligate the geniculate branches, decompress the popliteal fossa, and it works well with the short interposition bypass, whether it be prosthetic or vein. Both tend to do fairly well. And now that brings up the topic of a vein versus a prosthetic. The vein grafts, the patencies are very good in regards to the medial or the posterior approach. The prosthetic grafts posteriorly are not too bad. So there's no real difference between in the vein and the prosthetic, but when you're dealing with popliteal aneurysms, you primarily use the prosthetics just in the posterior approach. So endovascular repair, it's been around for decades now, and most of the reports are short series or whatnot. What we consider indications for endovascular repair would be with an aneurysm greater than 2 centimeters with intraluminal thrombus. You have to have suitable proximal and distal landing zones, and at least a couple vessel runoff. Relative contraindications certainly are contraindications would be aneurysmal disease throughout the SFA, so no real good landing zones or extensive requirement for treatment for the endografts. Involvement of the AT origin, so no good distal landing zones, tortuosity, and certainly large aneurysms with compressive symptoms, because you're really not helping the patient in regards to what's causing them problems with their popliteal aneurysm. And so again, you need a 1.5 centimeters, 2 or 3 centimeters in regards to landing zones. About 10% or 15% oversizing. You certainly want to not oversize too much in getting infolding of the grafts. Single stents are ideal, but oftentimes it's a couple stents, and if you have to put a couple stents in, you want at least 3 centimeters of overlap. There's a wide discrepancy of patency rates in these case series, and reintervention rates overall are probably in the mid-20% range in regards to people with endovascular therapy. And most of the patients are put on dual antiplatelet therapy and preloaded with Plavix and aspirin prior to their procedures. Stent fracture can be a concern, as this is as a mobile area in the body and at most joint spaces, so they need to be surveyed and watched for that. Another important factor in regards to popliteal aneurysms is thrombolysis. It's an important adjunct for the acute presentations in acute ischemia for the thrombosis at the popliteal area, as well as the thromboembolism. The primary indication for thrombolysis is no visible targets or no visible distal targets. So you're trying to enhance the patient's outcomes and outflow as far as their open interventions go. And looking at the role of catheter-directed thrombosis in this registry, about 42% of the people had pre-op thrombolysis, and the mean infusion time is about a day or under a day. Some of these acute people, though, however, if the limb is not viable and have to have about almost 60% required immediate surgery. But those who had thrombolysis, the runoff target is improved in almost 90% and found to have a decreased fasciotomy and amputation rate. So looking at the outcomes of the medial posterior approach, the short-term outcomes are pretty good in regards to graft patency and thrombosis. One thing you want to look at for the medial versus posterior approach, which makes sense, is you can still have aneurysmal growth in regards to the medial approach through some theoretical patencies of the perigeniculate vessels. And looking at the open versus the endovascular, early-wise, also the graft thrombosis stuff maybe a smidge more in the endo group, but you also have to, in regards, look at the aneurysm growth. Patencies may be a little bit better in the open side, but overall are not too bad. So, what are the best approach for patients who are eligible? Just like Dr. Height was saying in regards to amputations, you kind of have to tailor it a little bit to your patient, what their comorbidities are, and what they can tolerate. Certainly, stents are reasonably good in patients with the suitable anatomy. So it's really, this is kind of where you're picking the right patients. Operations, particularly vein grafts, are super, and in the right patient also can be very well. One thing that you'll find, and what makes being a vascular surgeon exciting, is the technology that's available. It's continuing to improve, and so things get better and better, and so there's always expectations that the endovascular therapy will likely also continue to improve. Don't forget to survey these patients. This isn't a put in a graft to fix and forget it. You got to survey them for graft patency, aneurysmal dilatation. Even in the open medial approaches, you need to watch for that. And vein graft aneurysmal dilatation over the long term also can be a concern. Well, thank you guys very much. Appreciate it.
Thanks, Todd.